Psychiatric conditions and behavioral problems in adolescents with intellectual disabilities, correlates with autism, a study by Bradley, Ames, and Bolton in 2011. Population-based studies have consistently shown greater frequency of psychiatric and behavioral disorders in people with intellectual disabilities compared to individuals in the general population. To date, there have only been two such studies that examine the coexistence of autism spectrum disorders and psychiatric and behavioral disorders. Both of these past studies show that individuals with autism spectrum disorders were at higher risk for psychiatric and behavioral disorders. A study showing whether individuals with ASD coexisting with other disorders or not who have a higher risk of mental health disturbances has implications for the distribution of resources. The authors clearly state the difference between episodic disorders and non-episodic conditions. Episodic disorders were characterized by clearly defined changes in behaviors from a previous usual pattern or baseline, and then returning to the usual behavioral patterns between episodes. An example of this would be someone who is diagnosed with bipolar disorder. Non-episodic conditions are background behaviors that arise more insidiously and may fluctuate in intensity, but are not distinctly episodic. An example of this would be someone who has compulsions. The authors then go on to state two key questions that the current study will attempt to answer. First, what is the degree to which non-episodic psychiatric and behavior problems are increased in people with autism spectrum disorders? Secondly, what is the degree to which these behaviors are associated with each other? There were 171 total participants in this study, 41 of which met the ADIR requirements for ASD and also had a nonverbal IQ of less than 75. 5 of those 41 participants dropped out early in the study. Other measures of this current study included scales to which the experimenters were able to measure the non-episodic conditions of all of the participants. Compulsive behaviors were examined using the compulsive behavior checklist, which was actually designed specifically for individuals with intellectual disabilities. This checklist consists of 30 compulsions that are arranged in 5 different categories. In order to assess anxiety, the experimenters would ask the participants if they were feeling nervous, on edge, anxious, or frightened in any way, in 2 regards, one being the content of an episode and the other as in daily behaviors. For fears and phobias, the experimenters simply asked the participants if they had any fears or phobias. For motor tics, it was observed in 2 different ways, a checklist and also observation. For stereotypy, the stereotypy checklist was used. It involved 35 different stereotypies in 10 different categories. The self-injury and self-restraint checklist describes 8 types of different self-injurious behaviors and also 8 varieties of self-restraint behaviors. Any episodes of those behaviors were also noted during observation. The experimenters also asked specific questions about any medication prescribed for autism, epilepsy, behavioral, or psychiatric concerns. To examine the distribution of non-episodic psychiatric behaviors, a one-way ANOVA was conducted. It produced an F value of 16.61, which translates to a p-value of less than 0.001. The analysis of between-group differences. For compulsions, they looked to assess how the compulsions interfered with daily life. In order to do so, a chi-squared analysis was conducted, which produced a p-value of 0.02. The observation ratings of anxiety was conducted using Mann-Whitney U analysis, which produced a p-value of less than 0.001. Again, for the analysis of between group differences for fears and phobias, frequency of which was taken using a Mann-Whitney's U analysis. It produced a p-value of 0.04. For stereotypies, self-injurious, and self-restraining behaviors, the total number of stereotypic behaviors was observed. Again, using the Mann-Whitney's U analysis, it produced a p-value of 0.03. For all of these analyses of between group differences, the results showed that the autism group exhibited these non-episodic behaviors significantly greater than the non-autism group. The authors give 4 reasons on why this current study was unique. First, adolescents were drawn from a population-based sample of adolescents with intellectual disabilities, circumventing the bias of clinic samples. Secondly, autism was identified using the ADIR, which is a standardized assessment tool for the recommended research in autism. Third, autism and non-autism groups were matched on age, sex, and intellectual level, and variables known to impact psychiatric and behavioral symptoms. Lastly, non-episodic conditions were evaluated separately from episodic disorders, such that episodic and non-episodic symptoms and behaviors were separately identified and assessed. While both groups showed a low prevalence of anxiety outside of the episodic disorders, the group with autism showed more fears and phobias and were observed to be more anxious during the direct observation. The diagnosis of OCD was particularly problematic in the current study, most likely probably given to the lower IQ scores. Although this were the case, the findings of the current study concur with others suggesting elevation in compulsion behaviors in individuals with autism, and also with familial relationships between OCD and autism. The authors list 3 limitations to the current study. First, the sample size did not allow for the full examination of the relationships between autism, problem behaviors, and medication prescriptions. The second limitation the authors list is that the participants were diagnosed with intellectual disabilities as well as autism. Thirdly, the diagnosis of OCD was not able to be made due to the fact that for the requirement, the participants were needed to describe the ego-dystonic interpretations of their episodes. The authors list a few implications for the current study. First, adolescents with autism are at a higher risk for OCD and stereotypies. Secondly, anxiety during clinical assessment was evaluated in adolescents with autism, and the phenomenon of anticipatory anxiety warrants future research. The third implication is that there is a need for a better way to diagnose OCD in special populations. Some areas for future research include to increase sample size, different samples of the population, for example, individuals within the normal range IQ, and also future studies could examine anticipatory anxiety. Thanks for listening!